Now that's about the acute hepatic failure. We will come to the management next. Then the chronic hepatic failure is the other way, and it's not very clearly defined as such. Most of the times the chronic hepatic failure is when the duration is more than 4 weeks and the patient has evidence of fibrosis or necrosis in the liver. That's which we categorize as a cirrhosis. Cirrhosis is defined as a necrosis, fibrosis and regeneration of the liver. When there is a partial regeneration and at the same time it's about the other issues. And in case of the chronic hepatic failure, most of the times you may not have the jaundice as the clinical presentation, but instead it's the hypoalbuminemia, like albumin concentration being reduced, because one of the important substance which is synthesized by the liver is the albumin, and when the albumin is reduced, earlier days when we were students, we used to depend upon only AG ratio, albumin globulin ratio, but now directly albumin can be assessed directly, and that albumin level being less than 6 grams is one of the most common causes the chronic hepatic failure. And in majority of the hepatic pathology conditions, when the routine investigations are done, many times this albumin assessment is missed. They are not done, either maybe negligence or somewhere. And if you miss that, many of the chronic hepatic failure cases also might be missed. So whenever we do a hepatic function test, liver function test, a assessment of the albumin also is very crucial. It should not be missed. That's another of the point, which is often missed, like next part. Now, there is one more variation, acute and chronic hepatic failure, which we see quite frequently. A patient with a chronic failure, then all of a sudden he develops an acute failure, and most of the times that condition is almost a death sentence. Acute and chronic failure conditions are almost, I say, a death sentence. With all that, whatever the availability of the treatment, virtually there is the mortality rate is very high, and it's almost 100% mortality, which we see as it. The only other solution now which is available is a liver transplantation. I'll just casually refer to that part also. So that's about one of the issues. And acute and chronic hepatic failure often can be misleading in the clinical presentation, because they may present with acute sepsis, acute septic pathology, and the hepatic failure might be missed clinically. Occasionally it can be missed. The patient may have uncontrolled infective presentation anywhere. Either it could be the pulmonary infections, or it could be the gastrointestinal tract infections, which can even result in a mesenteric vein thrombosis and a persistent bleeding per rectum, or it could be a cutaneous infections, where there could be significant pus, pyoderma-like presentations also can occur. And in that conditions, even if it is a septic pathology, total leukocyte count may not be very high. So usually in a septic pathology, you expect the total leukocyte count to be very high, and the total leukocyte count is one of the criteria by which we assess the severity of the infections. But in a acute and chronic hepatic failure, total leukocyte count will be moderately raised, or many times even may have the total leukocyte count less than the normal, but the patient may have a acute sepsis. That's also one of the misleading presentation clinically. Next part. That's about the general issues about the acute and chronic. Among the diseases which we treat, the majority of them are the viral hepatitis. Viral hepatitis is the most common. And many times people feel that all viral hepatitis are the same, but it is not true. The variety of the hepatitis virus which are identified now are many, and now it has gone to A, B, C, D, E. Maybe in a few days now already the next category, F and G categories also are being now identified, but still it hasn't come into the regular clinical practice. From our clinical point of view, the incidence of the diseases which we see in our area, majority of the patients whom we see are hepatitis A, and the next is the B, hepatitis B. So we will discuss something more about the hepatitis A and B. Hepatitis C is one of the budding disorder, new disorder which is coming up. Information about the hepatitis C in the Indian circumstances are very few, and that's, as I told you, WHO has already given a guideline, like there has to be a better method of screening for hepatitis C as such. Initially when we were studying, hepatitis C was considered to be an exclusive area of kidney transplantation or dialysis therapies. Dialysis patients, it was considered to be exclusive, but it is not so now. Primary difference between the A and the B, important is, A is transmitted by fecal-oral route. That's when there is a contamination of the food substance which is consumed, that results in the hepatitis A, whereas B is transmitted through the body fluids as such. Body fluids, either it could be the blood serum or it could be due to the sexual transmission or so on, where there is a possibility of exchange of the body fluids. The B virus can be producing the infections. The basic other differences are, the important is in A, the incubation period is usually about 2 weeks, 14 to 20 days, 2 to 3 weeks. Whereas with the B, the incubation period can be wide varying, even up to about 100 days. So many times the linkage between that infection and the presentation often can be missed. Whereas in the C virus, it can be as long as 6 months also. The incubation period can be 6 months. These are the misleading conditions it can produce clinically. The other viruses are not much significant from our present clinical point of view. So D and B can just casually leave it as such. The differences are not much, but A, B and very critical in our management and selection of the patient. C also now is becoming important. Then the outcome in case of A and B, they are different. So I will try to deal with that differences in A and B to a certain extent as such. Now, before going to that, the hepatitis, viral hepatitis A particularly is presented as epidemic, and India is considered as one of the treasure house of the hepatitis A, particularly A, it's considered, and India is always A grade. Now, you have that in the category, highest category. And the incidence is also maximum in those black colored states. The incidence is maximum. Blue, dark blue comes the next, Karnataka. That's in that state. And some of the states are comparatively, the incidence is lesser. And this also has some significance when you deal with the patients presenting with the jaundice. Most of the times now here, every person, or rather common man, would say that every jaundice is a hepatitis. They believe that every patient presenting with the yellow color, they will have a uniform identification, but that's not really the true issue. Next part, about that statistics. Another issue which is very interesting is, initially when we were studying, or earlier, hepatitis A was considered to be a disease presenting in only the summer season or rainy season, July, usually was the incidence rather. In winter and other seasons, the incidence were lesser. But gradually, the trend now, this is again from our national statistics level, the trend is changing, and from 2007 to 2011, in the past 4 years, the incident trend is changing. Now it has become almost throughout the year, though the incidence is maximum in the summer, or rather in the summer in the North India, rainy season here, in the July or so on, that is the month usual duration. But earlier, it was the maximum incidence was only in that period. Other seasons, the incidence were lesser. Now it has become present almost throughout, because virus grows much more effectively than the human beings. So they can survive in many of our weather conditions. Next part. Now the basic difference between the A and the B, I will not go into much of the theory detail, but certain of the issues which are very important from the clinical point of view. A virus, when it infects, it produces a immunological reaction, and the immunoglobulin will be raised, and that immunoglobulin will be raised, will remain raised for up to maximum of about 2 months. Then there will be no infectivity. Either a patient is cured, and once the patient has a symptomatic relief, after about 2 months, you will not find traces of the immunoglobulin in the body. Whereas with the HBsAg, that's the hepatitis B virus, the situation is something different. The immunoglobulin raises to the maximum in the initial stage, first about 1 or 2 months. Then for years together, or many times for the whole life, that immunoglobulin may remain active. Patient may have that, the immunoglobulin being present in the body for throughout the life. Virus also will be present in the body in a dormant stage. And that's one of the dangerous issues with the hepatitis B. So you will have many people who are otherwise clinically asymptomatic, but they will be hepatitis B carriers. Their serum would be positive, and these serum positive patients can transmit the disease to others silently, without really having that clinical presentation as such. And hence, when you have a patient with hepatitis B, the important is to screen the persons who have come into contact with that particular patient, and the possibility of a contamination of the serum product from the patient. Of course, now there is a universal criteria, like if the blood transfusion, if there is a need for collection of the blood, it's mandatory that you have to screen for 𝐻𝐵/𝐶G. That has become mandatory. It's not only the blood transfusion, it is the other way also. When you use the injections, syringes or needles as such, possibility of contamination through, and from the surgical discipline, patients who are operated upon, and if the patient is 𝐻𝐵/𝐶G positive, you have a risk for all the surgical team, including surgeons or others. So that risk assessment is one of the important issues. It's not only that risk assessment to the others, the 𝐻𝐵/𝐶G also is known to produce the delayed complication, next part, that it can result in later delayed term complication, like even development of the hepatocellular carcinoma. And it could be years together, and that's why you need to assess those patients and then effectively manage. The management part, I will come to that next part. So that's in brief about the hepatitis A and B. Next slide. Now, I consider all these viral hepatitis, both A and B, as Pitta-J Jwara. It is not Kamala. I don't consider this as Kamala, though in general, again, something different from the usual trend. Kamala, as such mentioned in the text, is a complication of PART-2, and in the delayed stages, ultimate stages only, the Kamala is produced, and it's not only about the yellowish discoloration seen in Kamala. Samhitas would describe about hundreds of diseases where there could be yellowish discoloration. It's not only the other. So I will come to the certain of the other diseases also later. But I consider them as a Pitta-J Jwara, and I treat all the patients of hepatitis as Pitta-J Jwara. The differences in terms of this A and B would be in terms of the total outlook about the treatment, but my prescription would be same, and the description in the text is exactly the same, like where you will have a 𝘔𝐸𝐵 and the 𝑉𝐸, the vomiting or gastrointestinal tract abnormality, and at the same time the possibility of encephalopathy, pralapaha, where the patient would have the possibility of encephalopathy signs, and where even kantos mukanasanam pakaha, possibility of bleeding from the oral or other areas. These are typically described, and in a very advanced stages it can result in a hepatic coma like madaha, murcha, etc., which also can be the other clinical signs, and hence it's very practical to consider all the hepatitis variety patients as a Pitta-J Jwara. Now, next part, the differences will be in advanced conditions where there would be an encephalopathy. Encephalopathy is described as the 𝑉𝐻𝑗, and which also is a complication of the Pitta-J Jwara only, or Tridosha Jwara, Sannipata Jwara or Pitta-J Jwara can produce the same, where the 𝑉𝐻𝑗 Pitta Anila Samuchayat, when there is a possibility of a Pitta and the Vata, that results in the 𝑉𝐻𝑗, and that's considered as a asadhya. 𝑉𝐻𝑗 nirodhajam tasya janiyat kushala-bhishaka, and these are considered as a asadhya as such. That's about the other important signs which we can make out. Now, next part. When a patient comes to me with a history of jaundice and the fever, which is usually, I will limit to that category of hepatitis conditions, the important investigations which are necessary are LFT, and when I say LFT, that albumin level is one of the crucial issue, and then the prothrombin time is a very important criteria. Screening for 𝐻𝐵/𝐶G, and important is 𝐻𝐵/𝐶G may not be positive in patients with the B virus in the first 1 week. So many times you may have to repeat that 𝐻𝐵/𝐶G after about 2 weeks. And then the USG also is necessary to see whether there is a chronic change or not. Hepatic changes like fibrosis tends to occur or not. These are the important issues. The management would be, the most important part would be the rest. In hepatitis virus, particularly A virus, it's usually a self-limiting disorder. Even if you do not give any medicines, patients may recover, provided there are no other complications. And best of the means to prevent the complication is rest. So absolute rest is required. When I say rest, it's not only sleeping. it's about the rest to the gastrointestinal tract. The maximum energy consuming activity of the body is digestion of the food. You do not really spend more energy when you climb the upstairs, but you spend more energy when you have taken the food and that food is being digested. And hence, the principle of Langhana is the most important, crucial part in the management of particularly hepatitis fever. Of course, in every Jwara condition, it's crucial, but there has to be more important priority. And the idea of the Laghu Dravyas. Langhana doesn't mean fasting. Langhana means administration of the Laghu Dravyas. It's the most important part, more than any of the medicines. And diet also, the only hepatoprotective diet, carbohydrate containing diet, lesser protein, no fat. That's the usual diet which has to be given, and that's exactly what's mentioned as Deepanam, Pajanam, etc. The quality of the drug should be of the same, the diet should be any of that. And my prescription is the same, 𝘉𝘢𝘐𝐵 𝐅𝑚𝐴 and Kumari as well. And the only important is, I would be avoiding hyperacute conditions, hyperacute liver failure conditions. It cannot be managed with our hyperacute liver conditions, as I told you, those who have a more severe coagulopathy, when the bleeding time is more or prothrombin time is advanced more than 1.5 or very many times more than that. That's a condition where virtually we can't manage with our medicines, or the conditions can be dramatically changed. All of a sudden there could be fatal complications. So I would try to avoid such patients. Subacute conditions definitely can be managed effectively if you follow this regime. The other important issue is the electrolyte imbalance. Many of the patients, they may tend to have a hypokalemia, potassium level tends to be reduced during the course of the management. So if necessary, potassium may be supplemented, or occasionally I do prescribe a potassium preserving diuretic like the aldactone. Occasionally, it depends upon that, but not in all cases. It's not necessary, but there is a need to monitor that. If there is a tendency for the hypokalemia signs, it needs to be provided for. The duration, of course, previous. The other differences between A and B is, in A virus, our total treatment can be 3 weeks, and after 3 weeks, definitely we can stop the treatment. But in case of the B pathology, hepatitis B, it cannot be limited to that. It has to be either 6 months or many times it could be more than that, till the patient becomes seronegative. And with these 𝐕𝐤𝐴G carriers, where the patient may tend to be, and one of the groups of the patients who come to us are of that category. They are diagnosed as 𝐕𝐤𝐴G carrier, and I don't know, somehow there is a word called as white jaundice. Many people say that it's a white jaundice and they come to us. Who coined that word, I don't know, but it's very popular in the society. Some of the people consider white jaundice as anemia. Some people consider white jaundice as this diagnosed 𝐕𝐤𝐴G. And when they go for either the visa or when they attempt for a blood donation, they know that they have become positive, and then they come for Ayurvedic treatment. And what I have observed is, in my clinical observation, those patients who had an episode of jaundice, they can be definitely made negative with our treatment if they persist with our treatment for either 3 months or 6 months. At times, rarely could be a bit more than that. Same, 𝘉𝘢𝘐𝐵 𝐅𝐴 Kumari as well. But those patients who never had a clinical jaundice, but they are 𝐕𝐤𝐴G positive, most of the times we fail to produce the negativity. The patient tends to remain positive, though the level of globulin may be slightly diminished, but they tend to become positive. And this is necessary when we give this counseling to the patient. When the patient comes to us, when you have to suggest like what could be the outcome. And in the patients who had never the clinical episode of a jaundice, it's difficult to manage. The reason I don't know. I don't have any obvious scientific reason to substantiate that, but this is purely a clinical observation. Like patients who never had jaundice but are 𝐕𝐤𝐴G positive, they are difficult to be treated in terms of making them negativity, though they are clinically normal. Clinically they may be seeming to be normal, but that risk of being a carrier remains as such. So that's one part. Next. Now the carrier state, that's, as I told you, the patients with the carrier state, they are the silent killers, and more than the damage to themselves, they can harm others. So it's important to screen the family members. Screen the family members is an important issue. Many times the whole family may be the 𝐕𝐤𝐴G positive without being aware of the situation. So it's a tissue. Again, the last outcome in all these patients would be, it can result in a recurrent hepatitis, it can even result in a fibrosis, cirrhosis-like changes, or even it can result in a hepatocellular carcinoma. For the exact time duration for these complications cannot be mentioned. Many times it could be many years, like 20, 30 years, or many times even throughout the life. At the end stage, you may know that the patient has hepatocellular carcinoma. So, sword of these difficult complications remain over the patient. But what I have observed is, if the patient follows the diet restrictions and with these medicines, we can postpone it for a longer period. But again, the problem would be to predict whether treatment has benefited the patient or not is difficult, because you do not know the exact time period by which the time patient has these complications. So as long as the patient is on our treatment, and if he has not developed the complications, we can claim that it's because of our treatment that the patient has not developed the complications. So the idea of the results is a bit question mark, but still I manage the patients with the same line of treatment like 𝐷𝑝𝑎𝑡𝑖S, 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 and diet restrictions, of course, is the one, right.